Welcome, everyone. It's the top of the hour, so we'll get started. I'm Dia Waguespack in Houston, Texas, and I'd like to welcome you to today's GlomCon seminar series. Today, our talk is titled Cold Cases of Cryoglobulinemia. We're very excited to have our speakers today in this case-based series, Dr. Zainab Obaidi. Our other speaker is Dr. Alana Dasgupta.
Okay, thank you so much, Dia, for the kind introduction. Good morning, everyone from Chicago. Thank you all for joining today on a Sunday. We really appreciate your time. My name is Zainab, as I was introduced, and I have the pleasure of co-presenting today with Alana, who was also a fellow at Hopkins when we met. So for today's talk, it's really meant to be case-based, so questions are encouraged. So if you have any questions, please put it in the chat. Or we can discuss it throughout or even at the end of the presentation. So really happy to be here. All right, so for this talk, I have no financial disclosures in this case. The patient's information has also been modified for the purposes of this presentation. And so let's get started. So for today's talk, the outline really is to discuss the case and then identify common causes of cryoglobulinemia, recognize key findings to diagnose cryo, and then identify some treatment options in these complex patients. And so to get started, we had a 43-year-old female, relatively healthy otherwise, diagnosed with history of metastatic melanoma back in 2017 due to sun exposure and sunbathing. And that recurred in 2024 and was started on immune checkpoint inhibitors, which was the ipilimumab and the nivolumab. That was started about 4 months ago before her presentation, and she basically presented to the ER with polyarticular arthritis and progressive lower extremity edema for the past 2 weeks. Nephrology was consulted for nephrotic range proteinuria with a creatinine, which was her baseline at 0.8, but her UACR and UPCR was at 3.4 grams. And to give you some context to this, she developed a similar episode of joint pains about 2 months ago that was attributed to immune checkpoint inhibitors and was treated with steroids. And at that time, she was switched to nivolumab as monotherapy following that, and her symptoms improved a little, but then obviously it flared up again this time around. So on review of systems, when we asked her further, she also noted discoloration of her fingers, tingling, numbness, and weakness that initially started over her lower extremities and progressed to her upper extremities, and mostly associated with weakness and tingling numbness. So it's both sensory and motor. Negative pertinent findings were she did not have any oral ulcers, no history of rashes, abdominal pain, no history of hematuria, cough, or any sinusitis, or any history of rheumatoid lupus in her and her family. The only pertinent past medical history is this diagnosis of melanoma that was in 2017 due to sun exposure, which tells you sunbathing is not good for you. And at that time, she was noted to have this right thigh lump and over her left shoulder that had a wide excision with negative margins, and dermatology was happy following that. But then, unfortunately, in the end of 2023, she had evidence of recurrence with supraclavicular lymphadenopathy and a right breast mass that was confirmed to still be melanoma on biopsy, and a PET scan was also evident to show extensive bone disease. And at that point, oncology was following, and they started her on these new immune checkpoint inhibitors, which is the ipilimumab and nivolumab. She was on cycle 4 at the 4th dose. And at that time, she did develop some rheumatoid symptoms in which they transitioned her to only nivolumab, and she got 1 dose of that around cycle 4. As we mentioned, family history was negative, no prior history of rheumatological diseases, autoimmune, or kidney disease. Social history, she was a non-smoker, otherwise very fit and healthy, and she was only a social drinker. And medications, other than her new immune checkpoint inhibitors, she takes PR and Advil for migraines occasionally. Now, on physical exam, the pertinent findings were vitally, she was a little bit hypertensive. She was admitted a month prior in which she had some adjustment to her blood pressure medications as a result of that. But on the date of admission, we could note that she had like a lacy rash. And if you can see close up, she also had these lesions that were non-blanching. And in her, she said she never had any history of purpuric lesions or anything like, but this rash was also of interest, and it was kind of fading away in her lower extremities. And as you can see, she also had polyarticular arthritis in both her hands. She also had raynaud's, which we don't have depicted in this picture, but was present also at the time of presentation. And so on initial labs, as you can see, her creatinine was normal at 0.8, her GFR was above 90, her, electrolytes were fine, hematological markers were on the normal side. What was interesting, though, is that her UA showed that she had +4 protein, +4 blood, more than 20 RBCs, and she had 10 to 20 WBCs, and her UPCR was at 3.4 grams. Interestingly, her albumin was at 3.1. Her ASTs, ALTs were fine. And what you could see pertinent here is her CRP was elevated. Her rheumatoid factor was elevated above 650, and it was fractionated to tell you that the majority of that was actually IgM. Cryo was weakly positive due to inadequate sampling at the time. SSA, SSB, all the autoimmune markers were all otherwise negative. And you can see here her C3, C4 were checked, and her C3 was normal. Her C4 was very low at 14. And we also spun her urine. We have some good fellows, so they spun her urine. But again, we didn't see any RBC casts. It was mostly hyaline casts on time of presentation. On further workup, neurology was also consulted due to concern of this neuropathy. An EMG study was notable for multifocal axonal sensory motor polyneuropathy concerning for vasculitic neuropathy, which also further increased or raised the flag that this is more of a systemic disease.